Now, I'm talking to you about GI, nutrition, and liver disease. Now, actually, the first organ system that ever forms is the GI tract. Remember your embryonic disc, right? The ectoderm invaginates and forms the tube disc. Everything else comes off that. The lungs are a bud off the foregut, okay? Really, the GI tract is central. It's core to everything. That's the first one to form. You know, do you think about breathing? No. Okay? Think about it, all right? But when you're sitting down there and you're at breakfast and they got those eggs with that sauce, right? And the muffins, a good meal, you know, you rub that tummy. GI tract is core. All right. I have interspersed in my slides, I do some missions work through my church. And so I have some, my dividers are some pictures from some missions trips. This is actually a flower from the Dominican Republic where I've done some missions work. And that's my dividers between my sections. All right, we're going to start off with nutrition. And I'm a certified nutrition support physician. So I have a special certification in nutrition. And my wife is a dietitian. My kids are like, why do we have a vegetable every meal? According to the American Board of Pediatrics, this is 5% of your exam. Now, a hint for board exam on nutrition. Most of the time, we don't worry about excesses of vitamins and minerals. Unfortunately, what's well known is the deficiencies, all right? So most of the time, deficiencies, all right? When you're thinking about vitamins, minerals, and all that stuff, it's deficiencies. So, nutritional deficiencies, the big picture. Caloric malnutrition or marasmus. When you have generalized caloric malnutrition, you get wasted. You look skinny, you look scrawny. I say they look like an 80-year-old man. Kwashiorkor is protein malnutrition. And when you don't have protein, you don't make the oncotic pressure producing proteins, and you get edema. And then you have what's fancy term is protein calorie malnutrition, and that's wasted with peripheral edema. All right, so caloric needs. Now, one of the good things about caloric needs is none of the formulas that have been developed are perfect, and none of them are very good. So that's great because really there's no formula you can actually use or test you on to know that. Your calorie needs vary by how old you are. It varies from individual to individual. Although we can give you some general parameters, the neonates are somewhere usually in the 120 to 140 range for calories per kilogram per day. And once you get to be an adult, it's 25 to 30 kcals per kilogram per day, which I really think is grossly unfair. Okay. The bottom line, and that's the important thing to take away, is that monitoring is the best way to ensure adequacy. The best test of nutrition is that growth curve, a piece of paper, and a pencil. Track them with time. If they're gaining weight, it may not be perfect, but it's adequate. If they're not gaining weight, it's inadequate. Tracking. And if they're going to ask you a question about growth, they're going to have to give you some tracking and some sort of information. If you can track it and they're gaining and growing, it gives you some idea. If they're not, it's not adequate. All right, so I'm going to use a few cases because it breaks up the monotony of the talks. A 4-month-old infant presents with irritability and diarrhea. All right. Of course, first-time moms are all irritable. After multiple formula changes, the mother has been feeding the child goat's milk. Does that ever happen where you guys are? It's amazing how many goats are out there. On physical exam, you note that the child is pale. You get a CBC. What do you see? Macrocytic anemia. All right, so that should raise a red flag right away. All right? Most of the information they give you in these vignettes are for a reason. Number one, they gave you goat's milk, and then they told you it's macrocytic anemia. Well, what causes macrocytic anemia? Well, there's 2 nutrient deficiencies that cause macrocytic anemia. Basically, folate and B12. Well, folate is a water-soluble vitamin. It's not stored, so you have to have a constant intake. We don't really store water-soluble vitamins. And a deficiency is associated with hematologic difficulties. All right? Primarily leukocyte, affects the immune system. It's the number 2 nutritional cause of anemia. Guess what? Goat's milk is deficient in folate and B6. So kids on goat's milk, so they're deficient in folate and macrocytic anemia. So they give you macrocytic anemia, which is, there's 2 causes primarily. And they tell you goat's milk, which is, folate, deficient as a substance. So voila. Think folate, think fat RBCs. Okay? That's my mnemonic devices. I'm going to give you my mnemonic devices. Now, that's the way I remember it. This is free. If you don't like them, you don't have to use them. But that's the way I remember them. All right. So here's a table. All right. And this is one of those tables you look at because, again, sometimes some of these I could go through a case after case after case, and sometimes you just look at the table and you try to remember the key points. Beriberi or B1 deficiency. You get paresthesias with beriberi. You get some wrist drop. Of course, if you have a severe case, you can have the Wernicke's encephalopathy. Riboflavin, B2. Flavin, flavor, tongue, sore tongue and cheilosis with riboflavin deficiency. B3 or niacin, I remember it as B3 because B3 deficiency is the 3 Ds, right? Pellagra, dermatitis, dementia, diarrhea. How many of you have heard it called pellagra? All right? All right. I've heard several pronunciations of that. That's the Corkins version of that pronunciation, all right? Pellagra. Paradoxine, or B6, there's a naturally occurring defect if you're deficient in B6, or you can treat it with B6 high doses. B12 is megaloblastic anemia. Folate, B12, and folate are the two megaloblastic anemias, and vitamin C deficiency is scurvy. Of course, that's famous because they figured that out with the sailors who didn't get any citrus or fruits, and so they became vitamin C deficient. They found out that they could give them limes, and they would not develop scurvy, and so the British sailors thereafter were known as limeys. Yeah. All right. So, water-soluble vitamins, those B's and C's, pantothenic, biotin, a lot of those water-soluble ones, most of them, if there's a deficiency, at least in the U.S., a lot of times there's some sort of a metabolic inherited disorder. The favorites for the exam: B12 deficiency in the association with neural tube defects, folate deficiency in the spina bifida risk, and vitamin C, which is needed for collagen, needed for vessels, bone junctions. You know, if you don't have vitamin C, you end up with these painful, brittle bones, and the teeth loosen. You get bleeding gums. Those are kind of like the big flags. If you see those, you start to think scurvy and vitamin C. All right, here's another case. Eric. By the way, these are fictional. Okay. 6-month-old had necrotizing enterocolitis as a premature infant, had a lot of his gut removed. He's on chronic parenteral nutrition. Had some low-grade jaundice, mild elevations of his liver functions. On physical evaluation, he has decreased reflexes. He's weak, and he has a poor ability to look upward. Now, a poor ability to look upward, that is like a flag. That's one of those kind of like when you see that in a history, you automatically think about vitamin E. All right. Now, E is a fat-soluble vitamin. Okay. You have to absorb fats to get the fat-soluble vitamins. Now, vitamin E is important in your circulating immune cells. Reticulocytes, hemolysis are seen hematologically, but it's also important for myelin. All right? If any of you like electrical stuff, myelin's like the insulator for our nerves. It improves conduction along the nerves, and especially the long nerve tracts. So you think the long nerve sites because that's where the insulation helps. You think E, think knees. Again, my mnemonic device. What other vitamins? All right? So if you got E difficulties, you got to think about all the other fat-soluble vitamins. A, D, E, and K, or ADEC. And again, that's the way most people remember this as ADEC. Short bowel kids have less absorption, less surface area, kind of one of those physics principles. Fat digestion requires 2 components. All right? You need your liver and you need your pancreas. All right? Fats don't mix with water, right? Oil and water don't mix. Most of our body is aqueous. So the fats and the waters don't mix. So the fat goes into our GI tract, the enzymes, the fluids are most of them aqueous. And so those fats, how are you going to get a digestive enzyme there, especially when it's an aqueous-based thing? Well, our liver makes the bile salts. And the bile salts are wonderful compounds because they have one end that's hydrophilic and one end that's hydrophobic. So what happens is the hydrophobic end goes in with the fats. And then they make these micelles around the fats. But the outside is hydrophilic, loves the water. And so the lipase and colipase, which comes from our pancreas, goes on the surface of the micelles, and they chew up the micelles from the outside in. So you must have a pancreas that works. You must have a liver that works to absorb fats. So any kind of liver disease, any kind of pancreas disease, you're going to have trouble with fats. And fat is where it's at. Okay. Well, if you think about it, all right, carbohydrates are 4 calories for every gram. Proteins are 4 calories for every gram. Fats, 9 calories for every gram. That's the reason breast milk and formulas tend to be 40 to 45% fat. Very concentrated source of calories. Of course, the other thing is fats are where all the aromatic acids are. The flavor, the taste are on the fats. All right. How many of you noticed that full octane, high fat desserts compared to low fat desserts? All right. Which one do you really want? All right. So let's talk about vitamin K. Now, vitamin K is obviously very important because it has a primary role in clotting. And we all like to clot. In fact, I think I have one right here from where I nicked myself shaving this morning. It's good that we clot. We need to clot. All right? It's necessary for 2, 7, 9, and 10, those clotting factors. Factor 7 has the shortest half-life. All right? Oh, thank heaven for factor 7. Shortest half-life, and it's vitamin K dependent. So the prothrombin time measures the extrinsic pathway, which includes factor 7. So in many ways, the way that you monitor your vitamin K deficiency, or for vitamin K deficiency, is by checking your prothrombin time. All right? Now, the thing you have to remember is vitamin K is named for the German spelling of coagulation. I know, we spell it with a C, but the Germans spell it with a K, and they're the ones who discovered vitamin K. So they can name it because they found it first. All right? Vitamin A, night blindness if you're deficient. You have immune dysfunction. There's a lot of things coming out on vitamin A on how it works with the immune system. And it's very important for that. The excess, you can get scaly skin, you get pseudotumor cerebri, and hepatomegaly. Boning up, another case. 12-month-old female presents for her 1-year checkup. African-American family moved to the northern United States 2 years ago. Let's say Minnesota for lack of a better place. Mother's been exclusively breastfeeding and started solids quite late. On physical exam, the patient is strikingly bow-legged, and she hasn't been riding horses. The fontanelle's still open. Patient has an apparent thick bracelet around her wrist. All right, so this is a case. The vignette's trying to give you a diagnosis. This is the way we write these questions, those of us who write some of these questions for the boards. We're going to give you the vignette. We're going to lead you to the diagnosis, and then we're going to ask you a question that's like diagnostic or treatment. And you have to have made the right diagnosis to get there. Okay? But hopefully we don't try to mislead you, but the idea is to get you be able to recognize the disease and then where you need to go with it. All right, so what labs do you want? Well, calcium. Well, you know, our body tries to regulate our electrolytes and our minerals pretty closely. So we have regulatory systems. So calcium and phosphorus are both pretty good until it's very late in the process. Oh, by the way, what was the deficiency? It was vitamin D. That's a vitamin D deficiency. That's rickets, basically. The prothrombin hormone, however, is very elevated. Alkaline phosphatase is elevated. And if you check the vitamin D, the one we check is 25-hydroxyvitamin D, was very low. Our body, again, tries to compensate and maintain all of our bloodstream and all of our electrolytes within a very narrow range. So therefore, the parathyroid hormone is trying to maintain our calcium and phosphorus in our bloodstream. So it's the parathyroid hormone that's probably the better measure to look at vitamin D and if you have rickets. Vitamin D deficiency leads to rickets. Now, vitamin D is very low in breast milk, so it needs to be supplemented. It's more common in darker pigmented skin tones, more common in the northern latitudes where the skin is and also when the skin is extensively covered. Think D, think bone, think thick. All right. How many of you would say you come from the northern latitudes? Northern latitudes? All right. See. Oh, so most of you are southern latitudes. All right. So not as worried about your vitamin D. Although if you're doctors, most of you probably spend most of your time indoors. Anyway, excess vitamin D, we do see that with constipation, renal stones, hypercalcemia, and myositis ossiferus. All right. Now here is the first, I don't know if they've had you practice with these. Here is the first of our group input. Get your keypads, all right? At the 1-year checkup of a healthy infant, the mother tells you she's a vegetarian, and she's going to raise her child as a vegetarian. You advise the mother that her child must be supplemented with what nutritional substance? All right? So next slide. All right, vote, guys. You got 10 seconds. Quick, quick, quick. Ah, very good. All right. And that is the right answer. All right. B12 for a vegetarian. In order to be complete, most vegetarian diets are deficient in these 4 substances: vitamin B12, iron, calcium, and zinc. Nutritionally, those are the ones we tend to get from some sort of animal product. These are great questions. Vegetarianism is on the rise. Great board questions. All right. Fluids. Now, again, this is in nutrition. This is under nutrition. So this is why it's like 5% of the entire exam. You need to know the signs of dehydration, because they'll give you a vignette. They'll give you some of these signs, and you need to be able to figure out the child is dry or not dry. How dry are they? So, the mild dehydration, the mucous membranes are a little dry. Their urine output's a little down. Moderate, you've got poor skin turgor, very little urine output, and the fontanelle is sunken. They'll usually give you an infant, and they'll be a little dry. And then severe, you'll have tinting, low blood pressure, no urine output at all. And of course, we all know the Holiday-Seeger method, that shortcut. It's not as accurate as using body surface area, but I don't know how many people actually do body surface area in that calculation. Basically because it's so hard to get an accurate height, and you have to have a weight, and so you have to figure out the body surface area and then do the multiplication. So most people do the weight and the rough rule of thumb, the Holiday-Seeger method, and that's pretty good for a board exam because it gives you pretty close to what one of the A, B, C, or D answers are. And really what you're after is the right answer. All right. Rehydration. Now this has changed in my lifespan, brief as it may be. Now, even moderate rehydration, we try to treat orally. In the old days, it was always an IV. We'd slap an IV in everybody if they're a little dry. We'd give them fluids, and we'd rehydrate them with the IV. Nowadays, basically, there are even folks who are advocating that if moderate dehydration, maybe we should put an NG down and give them fluids that way. I'm a certified nutrition support physician, all right? But would you rather have your GI tract figuring out what to absorb or not to absorb, and your kidneys kind of controlling and filtering things, or would you rather have me putting it into your bloodstream and deciding basically, well, this much potassium, this much sodium? Well, really, you want your GI tract and your kidney. They've been doing it a lot longer than I have, right? A lot longer. So basically, it's probably safer, a lot safer to do it that way. And so, even like I said, even moderate dehydration now, use NG, avoid IV. Severely dehydration, even also, they're recommending, hey, give them, bolus them IV, get them rehydrated, but as soon as you can, as soon as they start to take a little bit orally, then go to oral, or NG if you have to. Rupert. I like that name. I could never talk my wife into using it, though. Rupert is a 6-month-old who has an unremarkable past medical history. He has always appeared well-nourished, and his parents report that he will eat anything. He's from Memphis. He will eat anything. They're concerned because he has developed a yellow coloration of his skin. On exam, he does. He looks very yellow, but his eyes are not. This is keratonemia, and this is actually on the nutrition portion of the exam. This is due to a high intake of vegetables high in beta-carotene. It resolves with decreasing the intake of the responsible vegetables. You can have them decrease it and they'll get better. But the thing is, why would you? If they're eating vegetables, don't stop. Keep eating. Normally, all the labs are completely normal. I think carotene, I think carrot. Okay? These kids look kind of like they're carrots. It's actually kind of cool. I'm like, hey, if the kid likes vegetables that much, more power to you. All right. Another audience response. Now, last time we got 150 out of 200 of you guys. Come on. All right. Pick up your keypad. I'm going to read the history. I mean, this is anonymous, right, guys? This is anonymous. It's not, I'm not Mitt Romney or Barack Obama, you know. All right, you're not affecting the future of the country forever. We have a 13-year-old boy who has no weight gain for 2 years. He has chronic diarrhea, but no visible blood. Abdominal pain. On exam, he has no pivotal changes at all. He looks wasted. Scaly dermatitis and an erythematous rash around his mouth and his anus. What mineral deficiency is present? All right, now you vote. You don't do it on the first slide. You do it on the second slide. Oh. 182. Very good. All right, so again, this is an example, another, it's not a bait and switch. All right, not a bait and switch if those of you who ever took any economy courses. But they set you up. All right, so the vignette makes you think the diagnosis is Crohn's. But then we give you a nutrition deficiency that's very common in Crohn's, and it's zinc deficiency indeed. You've got to suspect Crohn's disease here, and what mineral deficiency is very, very common in chronic diarrhea. See, the GI tract, which is the most fascinating organ in the whole world. Let's take a poll. How many of you think it's the most fascinating organ in the whole world? Every hand should go up. All right. I'm lecturing right now. All right. All right. The GI tract lining is one of the most metabolically active systems in the body. The GI tract lining turns over every couple of days. Very, very rapidly dividing cells. All right. Zinc is part of the DNA finger proteins. All right. And you have to have that for DNA replication. Rapidly dividing cells take a lot of zinc. All right. And so, basically, if you're zinc deficient, you won't grow. When you have diarrhea, all those rapidly dividing cells, you're losing all that zinc. And basically, you very quickly become zinc deficiency with chronic diarrhea, which is one of the things you see with Crohn's disease. The other interesting thing is, if you are zinc deficient, there is one of our senses that is zinc dependent. Taste is zinc dependent. You develop dysgeusia or hypogeusia if you're zinc deficient. So, fascinating. I had a Crohn's patient, not the one in the vignette, his name was not Rupert, who developed zinc deficiency. He told me everything tasted like cardboard. Everything tasted like cardboard, which really is a double whammy. When you have Crohn's disease and your bowels are inflamed, you don't feel like eating, and then nothing tastes good. Really, that's a double whammy. So, of course, you have the acrodermatitis enteropathica type rash around your mouth and your anus. I call it the in and out rash with zinc deficiency, and that's a classic rash. You see that, especially somebody who has chronic diarrhea, you've got to think zinc. All right, so we're going to continue this case. Since he is so wasted, he's admitted. The endoscopy indeed confirms that he has Crohn's disease. So he started on total parenteral nutrition, all right, which is never total, actually. Many people prefer the term parental nutrition for replenishment. On the second day of his parental nutrition, he develops bradycardia to 40 beats a minute and hypotension. What's happening? And what do you measure? Well, I'll tell you what's happening is he's got refeeding syndrome. When you're malnourished, your cells don't have enough energy in them. The energy currency that is inside of our cells is ATP. That's where we store our energy, is in those phosphate bonds. When you're malnourished, you don't make ATP. You have AMP and ADP. Now, we can't have all that extra phosphorus floating around our bloodstream, so our body's regulatory system takes care of that. So what happens is you get malnourished and you don't have ATP, and then all of a sudden you start nourishing them. And all of a sudden they start making ATP again. And there's this big phosphate influx. And so basically the phosphate drops. Now, phosphate is an anion. Our bodies want to be electroneutral, so they need some cations to come with it. And that's usually magnesium and potassium to make it electroneutral. So what you'll see biochemically is you'll see a drop in phosphate, which is the actual physiology behind refeeding syndrome, and you'll see a corresponding drop in potassium and magnesium. Of course, if you don't correct this or you aren't aware of this, this can happen with enteral nutrition as well, and it can happen in moderate malnutrition. It doesn't have to be severe. It's been described with moderate malnutrition. If you don't think about it and look for it, you can have delirium or death. And as you have heard probably your whole careers, death is considered a bad outcome. Okay? What I remember is refeed, make ATP. All right? And I've seen this. I've seen it with inflammatory bowel disease patients admitted at the time of new diagnosis. You have to think, if they look moderately malnourished to you, you've got to check a phosphate. You've got to check a potassium. You've got to check a magnesium. Other minerals. Iron. It's the #1 nutritional cause of deficiency. #1 nutritional deficiency in the world, #1 cause of anemia. This is worldwide and in the U.S. The deficiency peaks between 6 and 20 months of age. Okay? If any of you have toddlers or have had toddlers, you know that they don't like meats all that well. The high iron containing foods they don't tend to take all that well. It affects their development and their cognitive abilities. And there's some good studies out of third world countries that if you're iron deficient and you're anemic, you can affect your development, affect your cognitive abilities, and what you lose back then sometimes it looks like you don't get back. So this is a long-term problem. It's one of those things, we find it early, we take care of it, we keep them out of trouble, we're going to have benefits for us in the long term. All right? I want every IQ point I can get out of my kids because they're going to have to support me in my old age. All right? Calcium, this is one of your trivial pursuit kind of questions. Calcium is actually the most abundant mineral in our bodies. Now, how available is it? Not very, because most of it's locked up in our skeleton. All right? 99% are in the bones and the teeth. Of course, there's a current trend of decreasing intake, and we have long-term skeletal concerns. There's a recent report that was released looking at the calcium and phosphorus intake of adolescent girls. How many of them drink milk? How many of them drink diet sodas? Yeah, diet sodas. We're doing a huge experiment, and we're going to see what happens in 30, 40 years when those girls become 50 and 60-year-olds. All right. So that was nutrition. All right. Again, think deficiencies. That's where you're looking for most of those questions, is on things that are missing. So gastroenterology, according to the American Board of Pediatrics, is 3.5% of the exam. We're going to start with symptoms, not diseases necessarily, and then we're going to do a top-to-bottom GI tour, all right? Because that's the most logical way to proceed in my humble opinion. You know, after all, we have that peristalsis that takes us through. All right. Vomiting. All right. Now, vomiting is a symptom. Vomiting is not a diagnosis. When you see certain things in your histories, now this works as well, obviously, for actual patient care, but when you see these certain terms in your history, in your vignettes, on your exam, these are what you should think. When you think bilious vomiting, you should think there's an obstruction somewhere. When you see blood, you should think GI bleeding. Fever, think infection. Emesis only, no nausea, no retching, you think reflux. If you see undigested food, nothing's been worked on, you think achalasia. Projectile, again, projectile, you think some sort of obstruction, pyloric stenosis, some sort of antral web, annular pancreas. Tens fontanelle, you think about increasing intracranial pressure. They like to do it with infants because they have that fontanelle, and they can tell you, oh, it's a bulging fontanelle. Tumor, meningitis, or an adolescent female. Oh, my word. An adolescent female with vomiting. What do you always think? Pregnancy. Absolutely. There used to be an old joke that, an adolescent female in the ER with abdominal pain, that was the first thing you did was a beta-HCG. Pregnancy, drugs, migraines, and bulimia. I have 3 daughters. Oh, well, we're not going to go there. Chronic vomiting. All right. So how do you approach this? How do you look at this? Abdominal ultrasound is usually where most people start first. It's very, very safe. It's very, very cheap, and it screens for a lot of stuff. Upper GI contrast X-rays. Again, I call it the plumbing check. All right. In a way, I'm a kind of a fancy plumber as a gastroenterologist. Okay. Endoscopy. Endoscopy is never first because it has costs and it has risks. But it, in many ways, is the best study for sorting out a lot of different etiologies. Cyclic vomiting. This is here because it really doesn't fit anywhere else. It comes under GI because they come to us because they have vomiting. But it's really not a GI disorder per se. These are paroxysms of vomiting, and I mean real vomiting. We're talking like exorcist vomiting, all right? Vomiting up their toenails, vomiting till they're dehydrated and have to be put in the hospital for IV rehydration. And in between episodes, completely normal. I mean 100% normal. Like eats normally, grows normally, acts, walks, talks, completely normal. And then they'll have these intense vomiting episodes. They'll usually have diarrhea with it. And they'll sometimes have weeks and months between the episodes where they are absolutely normal. The thing is, what really put this on the map was when somebody figured out that there's extremely strong family associations with migraine headaches. So, the physical exam is normal. You have this classic history. What do? Now, do you do a workup? You know, this is a tough call because if they're completely normal, you have a strong family history of migraine, the history is like, man, they're completely normal, and then they have this boom, these terrible episodes. A lot of gastroenterologists will actually not do any workup at all to do a trial therapy, all right? Because this seems to be a migraine variant of some sort. And basically, you treat it like you treat migraines, okay? Cyproheptadine, amitriptyline, propranolol. And a lot of times you do that trial, prophylaxis, the episodes will cease. Again, it's a tough call. And the workup is, and if they have they're kind of close to classic, but then maybe there's a little fuzzy things, and maybe it's a kid who spits up too. It gets very tough, and then you start getting in this gray zone where how much workup do you do, and do I do some and not a little bit? Very tough. But the classic ones, if they have a very classic history, most people would not do much workup. The big thing is awareness of this. You know, wow, this kid has episodic vomiting. And for you guys, you know, if you see a kid who has these episodes of vomiting, and they tell you in between it's like you never know he had anything like this, you should think cyclic vomiting. Abdominal pain, all right? This is kind of like right before your boards. Actually, school started in Memphis Friday, and we're already getting the phone calls. I got this kid. He's had belly pain, terrible belly pain for about a week or so. School's starting, all right? So let's talk about some associations with this. All right, you get a history, you got belly pain, you had trauma. What do you think? You think perforation, hemorrhage, some sort of musculoskeletal injury, or pancreatitis. Again, bilious emesis, intussusception, volvulus, an incarcerated hernia, adhesions. Of course, you had to have a surgical history to have adhesions. Peritonitis, you think, appendicitis, cholecystitis, or PID. An adolescent female, obviously you think PID, pregnancy, ectopic pregnancy, ovulatory pain. A current jelly stool should be a big, huge flag to think it's a susception. And melena, if you have a stool that's melanotic, that means it's been pretty well digested and you start to think upper GI bleed of some sort. Well, how do you assess somebody with belly pain? Well, it's interesting. You notice my list doesn't have CT scan at the top. I'm old school, I'm an old guy. Serial exams. Look at the kid, go in a little bit and look at him a little bit later. And go in and look at him a little bit later. Serial exams. How much do we charge for that? Pretty cost effective. How good are your clinical skills? Actually, honestly, the more exams you do, the better you'll get. Okay? We haven't gotten to the point in medicine yet where we never have to lay a hand on a patient. Labs, complete blood count is very helpful. If you have an elevated white count, that tells you something. If you're anemic, that tells you something. A urinalysis can be very helpful. The urinary tract often mimics as a GI problem. That's because the kidneys want to be part of the GI tract. Pregnancy test, okay? And, well, yeah, again, I have teenage daughters. That's always a big scare, Chest x-ray. I can't tell you how many times I've seen a kid and they have belly pain. They have a cough too, and you check, and they have like a lower lobe pneumonia. Okay? A lot of things referred. Our nervous system is very funny, and a lot of things get referred to a lot of funny places. So if you have you have some things that lead you that direction, check a chest X-ray. Ultrasound or a CT scan if they don't improve, although I think ERs now, they scan them before they take their insurance information. Just scan them on the way through the door. Okay. Now, you see the bottom line on the slide. If you look at the bottom line in these slides, if it sounds like an appendicitis, the answer is always surgery, not more testing. You got kids rupture faster. All right? Their appendix ruptures much faster than it does in adults with appendicitis. And if it is an appendicitis, it needs to come out. All right? If it sounds like an appendicitis. Now, what I'm saying is not something that could be. I'm saying if it sounds like an appendicitis, the answer is always surgery. All right? Always surgery. Again, if you've ever seen anybody who's had a ruptured appendix and you got peritonitis and you have those complications, you don't want to go there. And that's important to take away. All right? Now, I was mentioning the school kids earlier. Chronic recurrent abdominal pain of childhood, or functional abdominal pain. You notice the acronym is CRAP. Okay? All right? Yeah. And we're coming right into the season for that. All right? School is starting in Tennessee. In the next few months, we're going to get all these phone calls for kids that we need to see because of belly pain. They have lots of missed school. Overall, there's usually over 3 months of duration, although it might get better in the summers or Christmas break. Usually 6 to 14 years of age, apparent abdominal pain, stressors increase their symptoms, normal growth, normal exam, hemoccult negative, labs are all normal. Treatment is reassurance and education, or RED, I call it, the RED approach. Okay, reassurance, education, and dietary change. That's the answer to a lot of things. Okay, I say take out caffeine and the spicy, greasy foods. I call it the RED approach. We do that for a lot of things. The RED approach works for a lot of things. All right. What are the red flags? What are the flags, that make you think there's something organic going on in belly pain? Well, these kids have terrible pain, can't go to school, but they sleep. In fact, they sleep 10, 12 hours. That tells you something. But if they awaken with pain, now that's a little different story. The pain is in a funny location. They lose weight or they fail to thrive. They have fevers. They have a rash. It's hard to fake a rash. Hard to fake a rash. Joint pain, ulcers on their mucous membranes. There is blood in the stool. Now, I'm not talking about a stool that they pass and send to the lab, because that a lot of times is anal. Okay? I'm talking about a sample from within the vault. All right? If you're going to test it, do it right. Put on the glove, get the lubricating jelly, get a hemoccult card. That's the right way to do it. Anemia, elevated sed rate, and a family history. You can't throw family history out. There's a family history of documented ulcer or a family history of inflammatory bowel diseases. You can pick your friends, but God picks your parents. All right? All right. Here we go. Another case. We did very good last time because, we were in the 180s at least when it clicked off after the 10 seconds. But it is the second slide when you start to vote. This is my chance to be, Bob Barker or whatever and read the history. A previously healthy 5-month-old presents with acute onset diarrhea. On exam, he looks pretty well hydrated. You've seen children with a similar presentation all week. Most appropriate therapy is begin on a lactose-free formula, begin oral rehydration therapy, continue the current breast or formula feedings, change to feedings with a hypoallergenic formula. All right. You got 10 seconds, guys. There you go. C is the right answer, guys. C is the right answer. Infectious diarrhea, acute diarrhea. A lot of infectious diarrhea. Now, you're taught that it usually lasts 72 hours, can persist up to 7 days. But actually the truth is, some of them, for instance, adenovirus, some of the viral illnesses can last up to 14 days. All right? So the symptoms can last that long. So if it can last that long, you need to give it time. When do you think about a workup? When they're less than 2 months old? When they're bloody? The stools, that is. When they look sick, toxic appearing. They're immunocompromised. They're recently hospitalized. They're recently on antibiotics. And they have white blood cells in the stool. All right? Again, oral rehydration and they're dry. Otherwise, you feed through, even if they're vomiting. All right? The gut lining cells are unique, very unique. How are they nourished? How are the cells lining our gut nourished? Do they get their nourishment from the bloodstream? No. They're the only cell line in our body that doesn't take their nourishment from the bloodstream. Now, you have to have a blood supply because you need oxygen. All right? Our gut lining cells get their oxygen from the bloodstream. But the gut lining cells, they take their nutrition by pass-through. What comes in your mouth goes into your GI tract. Then the GI tract cells take their nourishment by what passes through them. So if you don't feed them, you get atrophy. And that's what happens in the short bowel kids who aren't fed. But what happens in diarrhea is when the cells are trying to replenish and reestablish a mucosa, if you don't nourish them, they don't have a supply of nutrients and building blocks to replenish the mucosa. So actually the literature tells us now basically that feeding is better. The recovery is better. Feed through, feed through, feed through. So even if they're vomiting. Now it's not appropriate if they have shock, obviously. Their stools are greater than 10 mils per kilo per hour. In other words, they have so much that's like a cholera level diarrhea. Or they have an ileus. Their bowels have gone to sleep. And that happens occasionally with viral illnesses. That's pretty unusual. Now, the things you want to avoid, obviously, is some sort of hypertonic fluid. Gatorade is the best one. Lots of parents also will use juices or soft drinks. And they'll give this kid this hypertonic fluid who's had diarrhea, and the diarrhea will persist because they're giving them a hypertonic fluid. And sometimes it's like, they'll come to see me, they'll be referred, and I'll say, put them back on milk. And then, they'll call me and say, it's gone. It's gone. I'm like, and I want to say, yeah, you're feeding them this fluid that's, these juices. What do we do for constipated infants? Give them juice. Why? Yeah. So feed through, feed through, feed through. That's now the recommendation. They don't recommend giving them pizza, but feed through. Normal diet, formula, breast milk. Feed through. That's the best way to approach diarrhea. How many of you read the studies on the brat diet? Any of you read the studies on the brat diet? You're lying, because there are no studies on the brat diet. There's never studied. Where did it come from? It was never studied. It was a tradition. I was taught the brat diet. Guess what? It actually has never been studied. If there is, it's got to be one of the newer ones that's been recently published, but there's no old studies. It was never something that anybody studied and developed, and this diet was developed for use in children with diarrhea. The brat diet, no. Actually, now what the studies show you, again, feed through. All right. What about some medications, all right? Or things that if it lasts more than 2 weeks, I do have to throw out. Occasionally, you'll see a child, they'll get enough villus blunting from an acute viral illness that they will end up temporarily lactose intolerant. I'll get on my soapbox a little later about lactose intolerance. But they'll end up temporary lactose intolerance, the most common type of lactose intolerance. And if they've gone and the diarrhea has persisted, you might want to do a short temporary travel lactose-free formula, do low lactose intake, and that's temporary. It will come back. Medications that are used in diarrhea, the absorbents, they add bulk. The stools look better. Guess what? They're still infectious. But you can get them to daycare sooner. So you have an ethical dilemma, all right? Okay, all right. Anti-motility agents slow them down. Actually, what we see with that, though, occasionally is they start using anti-motility agents. Then you induce an ileus. Then you can't feed them because their bowels aren't moving. You made more trouble than it was worth. Probiotics. Now, probiotics are a different story. Great literature now that probiotics shorten the course of diarrhea, especially in rotavirus. Great literature in rotavirus. And actually, there's now a formula that contains probiotics, and there's some work. It's not perfect, but it actually says that it actually seems to lower the number of infectious diarrheal episodes that happen during infancy if you're on that formula. So probiotics are something, it's not voodoo. It does seem to work. I think that those are actually probably changing your flora to a better flora are probably actually viable, and those are actually probably a good thing to do to shorten the course of a diarrheal illness. And in fact, I probably next year when I make this slide set, if they invite me back, is I probably will move that up to actually not just in a category of things that are medications to consider, but maybe it should be first-line therapy. We should just automatically do that. If you see diarrhea, you think about probiotics. Other things that have been used is somatostatin. That's kind of overkill. A little expensive, too. And bismuth subsalicylate, Pepto-Bismol, again. The pink medicine. At least there's a great dance you can do when you take it. All right. Constipation. Constipation is kind of a funny entity because lots of studies, but there's really no formal definition of what constipation is. Now, you ask any grandmother, she'll tell you what it is. Okay. But constipation is one of the things. There was a Supreme Court justice, and they were asking him about pornography. And he says, it's very hard to come up with a definition. He says, but I know what it is when I see it. Okay. Constipation, is it frequency? Only stooling once a week, is that constipation? Or once every 3 or 4 days? Is it consistency? As my daughters joke about pooping a brick, is that constipation? Is it discomfort? Is it just uncomfortable when you poop? Is that constipation? So it's not really defined. Now, and normal has such an extensive range. I was taught the rule of 7s for infants. The normal range of stooling in infants is 7 times a day to once every 7 days. That's the normal range in infants. That's a pretty wide range. Children can go 3 to 4 days between stools, and if they're gaining and growing, it's not uncomfortable. Is that constipation? Well, if they're not uncomfortable and they're not having any other issues, is that a problem? In children, of course, I'm going to tell you the most common cause of constipation is not some biochemical process, not some terrible disease, not obstruction, not something anatomic. It's functional or behavioral. Discoordinate stooling. We get some referrals for this. Infants up to 10 to 12 weeks of age strain and cry when they need to stool. Now, as you guys know, infants are very poor communicators. And any of you who've had children, you've tried to talk to your infant and reason with them, and you don't get very far. You notice that? All right. What it is infants will feel the need to poop, the urge to stool, but they don't necessarily realize that they have to relax the anus to let the poop pass. I call it bouncing a rubber ball off a brick wall. Okay? They actually will strain and strain and strain and strain and strain, and eventually the poop will come out. Again, this usually takes up to 10 to 12 weeks of age, and they'll figure it out. The thing you don't want to do is go the suppository enema route, because what that does is that creates more negative feedback to the whole pooping process. You have to reassure the parents. You have to make sure things are normal. But if everything is normal and it's a kid under 12 weeks of age, and they give you a classic history, this discordant stooling, you need to recognize and reassure. Wow. This is like a week on the PICU. Okay. Constipation. This kid's pretty darn constipated. All right. Psychogenic. Now, our colon absorbs water. That's its main job. In an adult, the studies have been done pretty well. When we eat a meal, all right, you sit down, you look at that filet, your fries, or baked potato, depending on what you like, your salad to kind of balance it out, your cheesecake at the end. You eat that meal, you put in some saliva. some gastric juices, some pancreatic juices, some liver juices to digest this. In an adult, with every meal, we actually add about 1 liter of digestive juices. That's every meal. Now, if at the end of our small intestine, when we were all done digesting it and absorbing the nutrients so that we were slightly under tall for our weight, we dump that fluid out, we get dry pretty fast. All right? So we have the colon. Now, it does other things. Don't get me wrong. It's very important. But its main job is to absorb water. But the colon does not have a sensor for fluid content. It does not have a shut-off switch. As long as the poop is in there, the body will continue to dehydrate it. All right? So what happens is we have a kid. Sometimes they're busy. They're hyperactive. We see a lot with hyperactive kids. They have a fissure because they've torn, because they've had a hard stool. They don't want to poop at school. Nobody poops at school. Nobody poops at school. They want to poop at home. All right? There's also some literature about kids who've been sexually abused. Now, not every kid who does this has been sexually abused. All right? But there is an association as well of kids who've been sexually abused. They withhold their stool. When they withhold that stool, more water gets taken out. It gets hard. When they pass it, it's painful. All right? Now, I don't know about any of you. There may be a few in you here, but I am not a fan of pain. Not a big fan. All right? So it hurts. Well, what are you going to do the next time you need to poop? All right? I'm going to hold on to it. When I hold on to it, what happens? More water gets taken out, it gets harder and bigger. You can see where this is going, right? It's a vicious cycle. It's a positive feedback loop. And it begins being reinforced. Then they get colonic dilation. They get overflow soiling because the liquid stuff from above just leaks around. And they have the overflow soiling. This is like 2% of all kids that come into a pediatrician's office. All right, this fecal smearing, encoparesis, lots of different titles, different places, but it's a very common problem. You put them on softener alone, you just put them on a softener, and the soiling gets worse because you've made it more liquid coming from above. All right, you're not going to get these kids better until you get rid of the roadblock. Okay, you have to clean them out until the impaction's gone. They're going to continue to do what they're doing. Then basically you need to put them on a long-term softener, not a laxative, a softener, and have them sit on the toilet regularly. You've got to extinguish their withholding response. You got to get them comfortable toileting on the toilet. Eventually, most of them will come off the meds once they've got a good bowel habit established and they're toileting regular. But there's a very high relapse rate. Like they'll do fine, and then school will start again, and they'll go back to it. All right. All right, so you're ready for the top down? All right. So, esophagus and trachea. As I told you before, the core of everything is the GI tract. All right? The trachea develops as a bud off the foregut, and then it separates later into 2 passageways. Now, you guys know that Murphy's principle, that if something can go wrong, eventually it will. All right? So if there's incomplete separation, if you think about all the variations in that separation process, what can happen? There can be a connection. Or it can pull away, and the bottom part can pull with it. And so all sorts of things in the whole TE fistula realm makes sense when you think about the embryology. Most common is the tracheoesophageal fistula with esophageal atresia. That's the most common one. The esophagus ends up being a blind pouch, and then the bottom part of the esophagus actually gets pulled away with the trachea. That's 90% of all the TE anomalies. It's 1 in 4,000 live births, so this is something you'll see. This is not an unusual one. 1/3 of them will also have other anomalies, and you got to know Vactral. All right? Vertebral, anal, cardiac, tracheoesophageal fistula, renal difficulties, limb difficulties. Basically, you try to place an NG after birth, and you look at a chest x-ray, and it'll tell you pretty quickly. All right, so here's an x-ray. All right? Now, when you look at this x-ray, what do you see? Well, look at the one on the left. All right, you're looking at it, you're kind of like, huh, where's the NG? Where's the NG? Oh, wait a minute. Wait a minute. What's that at the very, very top center? Oh. So you look at the right one, and that's a lateral view. They did a little lower. The shoulders are down now actually in the plane of the film. Oh. Huh. There's the NG. It's looped and it's come back up. This is a esophageal atresia. See that? All right. Of course, you can also see, again, any variation, all sorts of variations. Isolated esophageal atresia with no fistula. Of course, no air is going to get in the GI tract then, so you're going to have this flat gasless abdomen. You can't piss an NG, and of course, you have excessive secretions because they go in that blind pouch and they can't go anywhere. The H-type fistula, now this is the famous one because the H-type one is the one that you can get to adulthood with, and there's a little opening between your tracheal passageway and your esophageal passageway, and you can get pneumonias and all that. And, I've been looking my whole career for one, and my partners have seen one, and this is very rare. But you choke during feeds, you'll have pneumonias. Tough to see in a barium swallow because the barium doesn't always hit that little shunt pathway. Again, there's a case reports of adults, and they've had it their whole life, and they show up with it. The other thing is when this separates or whatever, you can also get some things that aren't, what you'd think of as in the tracheoesophageal fistula or atresia kind of things. You can get an area of narrowing where it's kind of pulled and it's kind of just narrowed, or you can get webs. And again, those are just developmental kind of short circuits for this development. And again, sometimes you'll see infants who do great with formula because it's liquid and they start solids. And they'll start having vomiting and those kind of issues, basically because they have a web or a narrow spot in their esophagus. Again, a lot of those you can just treat with taking an endoscope in them and looking at it and doing a balloon dilation of that, and that'll treat it without having to do surgery or anything like that. Achalasia. This is a neural problem, and the LES doesn't relax. So the esophagus will dilate above it. When the esophagus dilates, you lose your peristalsis. You don't have the good muscle tone. They'll present with dysphagia, regurgitation, and pneumonias because they regurgitate and it basically ends up flowing into their lungs. Infants and young children, primarily you see it as part of some syndrome, like AAA syndrome. It's very rare in children. It's treated with pneumatic balloon dilation. Most of the time, if you see achalasia in a child, you got to look for other things. It's part of the syndromic process. All right, another vignette question. 4-month-old brought to clinic because he spits up. Growth parameters are excellent. Weight's at the 50th percentile. The material is described as just rolling out of his mouth. Not distressed by this, he'll smile at you while he's spitting on you. The physical exam is normal. The appropriate response is vote. And D is exactly the right answer. What's this child have? Reflux. He has reflux. I didn't hear reflux disease. He has reflux. There's a difference. We talk about GER and GERD. All right. How many infants have reflux? All. All right. One of the breakthroughs a few years ago was when they figured out that infants have something called transient inappropriate relaxations of the lower esophageal sphincter. Our lower esophageal sphincter is one of those muscles in our body that is held tonically contracted. The vagus nerve, and the parents think like Las Vegas, but it's not like Las Vegas, it's Vegas. The vagus nerve sends a signal to our lower esophageal sphincter to stay closed. Constant signal. But you guys know that infant nervous systems are immature. Infants don't walk. Infants don't talk. You can't reason with infants. They cost you money, and you can't even talk them out of it. So the nervous system forgets at times to tell the LES to stay closed. That happens in all infants. Even infants that don't spit up, they actually have higher incidence of these TISLs. They all have some reflux compared to normal. All right? So as the nervous system matures, it's going to get better tone and better control, and they're going to get better with time. So reflux, all infants have some. Reflux disease, of course, is when you start to see health effects. All right? Failure to thrive, pain, wheezing and asthma kind of symptoms, aspiration and pneumonia. When you start to see those kind of things, we cross over, we start calling it reflux disease. One of my pet peeves. How many of you had barium for breakfast? All right. How many of you think barium is a normal physiologic substance? All right. Barium doesn't empty normal. We use it because it's a contrast medium, and it gives a wonderful white appearance on X-ray. Great studies have been done looking at this. You cannot diagnose reflux on an upper GI. Not only is barium not a normal physiologic substance, but how long does it take to do an upper GI? Minutes? An hour, maybe? Is that really a reflection of the whole 24-hour day? How many of you have ever eaten at a Mexican restaurant, had some capsaicins, which are in Mexican foods, and had reflux afterwards? We all have some reflux. The only time I've ever done a pH probe, which is a study we can do, and saw 0 for reflux index is somebody who's had a fundoplication. All right? So an upper GI is not diagnostic for reflux. And it has a very high false positive rate because, again, barium doesn't empty quite normally. You've got one snapshot in time. If you see an episode of reflux on an upper GI, does that diagnose reflux? How many of you have at least one reflux episode a day? All right. Now, gold standard, I'll admit. Right now, pH probe is a semi-gold standard. It's the best we have. It's not great. It does allow you to correlate acidic time with esophagitis. That does correlate. If you have a symptom log, you can correlate it with symptoms. And, if they have heartburn and they have reflux when they have heartburn, and it correlates, that helps. That's probably the best study we have for diagnosing reflux, but it's not perfect. Endoscopy, cool. I'm a gastroenterologist. One of the reasons I'm a gastroenterologist is because I love doing scopes. It is kind of cool. It's a great skill. All right? And you can document esophagitis. So if you do a scope and you see esophagitis, you pretty much know there's reflux because, again, there's effects on the tissue. Scintigraphy studies, your nuclear medicine studies, you can see aspiration and emptying time. And some kids will vomit, and it's not reflux. It's delayed gastric emptying. They have a sluggish stomach. So that's helpful for those kind of issues. If you see a kid and they say, hey, they're vomiting 2 or 3 hours after they've eaten, they're vomiting clear up to their next feeding. Well, wait a minute. That doesn't make sense. Reflux is usually right away because the stomach empties in an hour or two. So if that kind of a history, you maybe want to think that it's not reflux, it's delayed emptying, and it's secondary reflux. So honestly, we usually make the diagnosis of reflux by history, but there are now studies coming out that basically show that history is not super good, unfortunately. It's pretty inaccurate as well, but that's the way we approach it nowadays. Reflux, again, not disease, reflux, gaining and growing, happy, smiling at you as they spit on you, that's a reassurance issue. It's a laundry problem. The more gray hair I get, the better parents will take that from me. The younger you are, the more they look at you like, come on, this kid's spitting up on me. All right. There is a little literature, of course, that thickening the formula helps. There's also a little literature that if you thicken the formula, they'll end up gaining too much weight. So this is a balance issue. GERD, again, kids who are like failing to thrive. The PGI Society, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, which is the society that PGI docs belong to, just a couple years ago put out some guidelines on kids with reflux. And basically, the literature supports the fact that a high number of these kids have a formula protein allergy. And if you have any kind of suspicion, they recommend a 2-week trial of a low-allergy formula for kids who have GERD. Not GER, GERD, some sort of effect, especially failure to thrive. Formula thickening and concentration. If you have failure to thrive, they're spitting up a lot. The calories aren't going to hurt them because they're failing to thrive. Thicken, concentrate their formula. Again, there's some work, acid suppression, promotility agents, if they're slow emptying, that you need to think about. Some people believe that if it's a kid who's otherwise neurologically normal, maybe you want to do NG feedings for a while. Kind of do drip, do it slow, give them a chance to grow and develop until their nervous system is caught up with the rest of them. Obviously, esophagitis, you treat it with acid blockers. Especially if it's a neurologic kid, you want to prevent Barrett's because that's a precancerous lesion. You want to prevent strictures. We see those occasionally. Respiratory problems, you try to treat them very aggressively. Medications first. If the medications fail, you think about surgery. Kids who have neurologic issues, of course, are a whole different category. These kids are probably not going to improve with time. They're probably going to get worse because their calorie needs are going to go up. Then you start to think about surgery. Now, the most common surgery done is the Nissen fundoplication. The trouble is with the surgery, the kids are going to grow. They're going to get longer. And the literature tells us a lot of them end up needing more than one surgery. So it's very difficult because you know that they may need another surgery. Well, how long does it take? Well, 4, 5, 6 years. That's what the literature would tell you. So, do you drag your feet for a while and then do the surgery? Do you do the surgery right away? So, again, these are not things that are sorted out. But the kids who need to think about surgical intervention are the ones that have some sort of neurologic difficulty. That's really the take-home message. Eosinophilic esophagitis. I remember when I was in training, I was young, I was skinny, my hair was brown. We had these kids, and they had like reflux symptoms. But we'd treat them for reflux, and they wouldn't get better. And we'd scope them, and they had these biopsies that show all these eosinophils in the lining. And now, it's pretty clear that this entity is a different entity. It's eosinophilic esophagitis. Pretty clearly is allergy. It's a manifestation of allergy in the esophagus. They don't get better with acid blockers. And basically, sometimes you get lucky and you get allergy testing and it'll be positive, and you take it out and it'll get better. But the trouble is, there are hundreds and hundreds and hundreds, maybe thousands, of proteins in the foods we eat. Think about like an egg. How many proteins are in an egg? And all you have to do is have an allergy to one to develop this kind of a process. So, that's now, the allergy testing doesn't always help us. So, your treatment options, all right? Well, there are two approaches that people take. One is an elimination diet or an elemental formula. And then you add back things one at a time, and if they develop symptoms, then that's probably what it is. It depends on where you trained or who you worked with, how you approach this a lot of times. The trouble is, of course, man, if all you take is an elemental diet, have you tasted any of the elemental diets? Not exactly something that you have, elemental diet bars everywhere where people kind of walk up and take their elemental formula of choice. Not that tasty. The other approach is topical steroids, all right, where you take some sort of sometimes an inhaler based medication that's designed for the lungs, but you'll ingest it, swallow it, so it coats your swallowing tube. And that's been very effective as well. It's not treating the symptoms, it's treating the inflammation. We don't know what the allergen is. Again, this is one of those disorders that is on the rise. We're seeing more and more of it. Again, we're learning more about it, but we're still working on what's the long-term outcomes, what's the long-term treatment that's the best for this. Esophageal infections, some associations. Again, best way to do this is to look at this table and put it into memory. Things that predispose you to have esophageal infections are diabetes, HIV, cancer, and high-dose steroids. And the common ones, of course, are Canada's number one. A lot of times, a lot of cancer patients will get candidal esophagitis. CMV, herpes, these viral ones, obviously, kids see them for the first time. They've never seen them before. And the first time, for instance, they get herpes simplex type 1, they'll get the mouth ulcers, and sometimes they get a terrible, terrible esophagitis with it, and some terrible ulcerations, and they don't want to swallow because it's painful, and they look very sore if you scope them. Occasionally you'll scope them and look at it. It's very sore. The good news is, if they're a normal kid, it's self-limited, and they'll get over it. Now, some of the immune-compromised kids that are the predisposed kids, sometimes you have to intervene with an antiviral agent and approach it that way. Again, they'll have dysphagia, odynophagia, and then they'll have the chest pain with us. Caustic ingestion. It's interesting. You'd think with the child-proof bottles and the things we have nowadays that this would go away. But I can't tell you how many times that I've seen this. Within the last 3 weeks, Had some parents who borrowed a cleaner from their friends, took it home as an alkaline pH of 10 cleaner, and the parents just borrowed some from the friends, and all the friends had to put it in was a Gatorade bottle. Put it in a Gatorade bottle. So what does their youngster do? Finds this Gatorade bottle. Now, it doesn't look like Gatorade, but it's in a Gatorade bottle. What did the child do? They drank it. Absolutely. Acidic tastes bad. So things that are acidic taste bad, but the alkaline was actually, as far as our taste buds are concerned, are tasteless. All right? So a kid drinks a cleaner, drinks laundry detergent, drinks something that's alkaline. The key time to look at them is in 12 to 24 hours. If you look at them before 12 hours, sometimes it looks very normal. You don't see anything. After 24 hours, that's when the necrosis is really starting to set in and you have an increased risk of rupture. They call it the 12 to 24-hour window. That's really when you can look at it, you can see the inflammation, you can see the changes, you can get some idea how much damage or injury was done. After that is dangerous. So that's what we in GI look for. We look for the 12 to 24-hour window after an ingestion. Don't induce emesis because you're going to bring it back through again. You're going to double the injury time. Don't try neutralization. How many of you remember chemistry when you mixed an acid and a base? What'd you get? You got a lot of heat's what you got. You get a lot of heat. Don't place an NG because you're doing it blindly. You're not stirring this. And again, if you have a big burn or a big area of injury, again, you can end up puncturing the esophagus. So we don't recommend doing an NG. What's the treatment here? Well, in the past, people have done high-dose steroids. They've done antibiotics. There's no studies. Unfortunately, nobody has enough of these kids to really do a study. I'm glad that we don't see enough to where we can actually do a randomized study. But everybody has 1 or 2 or 3 or 4 a year. And we used to do high-dose steroids and high-dose antibiotics. But when you talk to folks, it really doesn't seem to help. It really doesn't seem to help. Unfortunately, what we end up doing is waiting with time. If they develop a stricture, we end up dilating it, or successive dilations. It will often get better with time. The severe cases end up needing the surgeons doing some sort of a surgical procedure to resect the area that's strictured. Rarely, if you get a severe long section burn, they'll actually do like a colonic interposition kind of thing. It's awful. It's a tragedy when it happens. Pill esophagitis. This is, in my experience, again, I'm coming beside the stage. This is a Corkinism, all right? Okay? I don't have any literature on this, all right? So I'm telling you this is a Corkinism. In my experience, this is almost always teenage boys, all right? Teenage boys do this. They're in a hurry, and it's a machismo thing, all right? I can think of my tetracycline, and I can swallow it dry, all right? I don't have time for water. I'm out the door. Give me my tetracycline. They swallow it dry, okay? Of course, what happens is when you swallow it dry, that pill starts to break down a little bit, and it can get stuck before it gets out of your esophagus. And then some of these drugs are very caustic to the mucosa, and they'll end up with it stuck in their lower esophagus, actually glued. I've seen a pill glued to the esophageal wall because it started to break down and they tried to swallow it dry. The big offenders on this are tetracycline, doxycycline, aspirin, and some of our heart kids. NSAIDs, again, this is the season 2 where we start to see that. Summer, football started, and you started your 2-a-day workouts, and you didn't work out all summer, and you know how that feels. I remember that. And then you're taking ibuprofen by the handful, and you swallow them dry, and then, yeah. Another one is the cardiology kids, the slow-release potassium will do this. Foreign bodies, which are actually not made non-domestically. Most common are coins. Kids love coins. They love coins. In fact, what's interesting is, I'm a gastroenterologist. I don't leave coins and stuff laying around the house. But I still remember when my kids were little, finding one of my young ones when they were little. She had a coin. She found it. I don't know where she found it. But she found it on the floor, and she's playing with it. I'm like, ah! Because the most embarrassing thing as a gastroenterologist would be to take your kid in for a foreign body. Think about that. All right? If they're stable, you can watch them for 12 to 24 hours. A lot of them will pass. What will happen is they'll relax, and they'll pass. And honestly, truthfully, I guess this is actually being videotaped. A lot of times what happens is when you take them finally to the OR to scope them to remove it, they get a little anesthetic and they relax and it passes. Then you pull it out of the stomach because you're there anyway. On chest x-ray, the coin is face forward. All right? If you guys remember your anatomy, the trachea is C loops of cartilage, right? And there's a soft spot in the back in front of the esophagus, so when you swallow, the food bolus goes through there. So if you swallow a coin and it ends up in your trachea, the edge of the coin tends to wind up in the soft spot, so it tends to be on edge towards you. The esophagus is collapsed when not being used behind the trachea. So if you swallow a coin and it's in your esophagus, it tends to be flat or en face towards you. Occasionally, older kids will see meat. Again, teenage boys. You know, they don't have time to chew. They've got to get it in. Okay? They'll take that bite, they'll swallow that meat, and then you'll see this big old chunk of meat. Last kid I saw was actually venison. They'd been deer hunting. Big old chunk of venison down in the distal esophagus. Kind of, you know, yes, deer meat. The endoscopy is obviously, in my opinion, the method of choice. You know, some radiologists will do a Foley method where they'll pass a Foley, pass it, blow it up, and pull it past. But to be honest, it can flip into the trachea. And I really like doing it by endoscopy because I have, you know, a foreign body grasper. I get a hold of it. I can see it. I pull it out right, you know, with the scope, watching it. So I actually have control of it. If you see a child who's older who has a foreign body, you have to think about the eosinophilic esophagitis. Some swelling and some inflammation from the eosinophilic esophagitis. You know, I saw a 10-year-old who'd swallowed a dime and had gotten stuck, and the kid had eosinophilic esophagitis. I'm like, why would a 10-year-old not pass a dime? He had eosinophilic esophagitis. Now, this is a child. This is actually an MRI scan. It's not the classic way to do it, but this kid had an MRI scan of the head and neck for difficulties with swallowing. I don't know how, but somebody sent me the film, and that's a coin in the esophagus. See it? See the coin in there? Again, we don't do many MRIs to look for coins. All right. Perforation, esophageal perforation. You see this in the connective tissue disorders. Ehlers-Danlos, Marfan's, epidermolysis bullosa, endoscopies obviously got a little risk in these kids. You do it with some trepidation. Borhave syndrome, spontaneous rupture. In older children, you see it with the severe coughing episodes, vomiting, straining, barotrauma, blunt chest trauma. In a neonate, if you see a spontaneous rupture of the esophagus, you got to think about a muscular defect of some sort. All right. Ready for another question? Here we go. 8-week-old presents with projectile non-bilious vomiting. Electrolytes show hypochloremic alkalosis. On ultrasound, there's a thickened pylorus. The next appropriate step is what? All right. The correct answer is A. All right. The correct answer is A. Now, being by nature a somewhat hyperactive person, I understand those who picked B. Okay? I understand why. But actually, honestly, this kid has, I told you in the vignette, hypochloremic alkalosis. This kid's electrolytes are not in line. They're out of whack. So before you're going to do anesthesia in this kid, you need to correct his electrolytes. And you also probably need to rehydrate him, okay? Because these kids also tend to be a little dry. Pyloric stenosis is very common, 1 in 200 to 1 in 750 live birth. Boys are 6 times more likely to have this. It's that Y deadbeat chromosome. Okay. On the other hand, I've also seen I see all sorts of girls with this. And one time I was actually said, well, this is a girl. And I said, boys are 6 times, but 1 in 200 children have this. There are going to be girls. You're going to see girls. And if it's a girl, you don't say, well, she can't have pyloric stenosis because she's a girl. All right? So tendencies are not 100%, right? So just FYI, don't ignore girls. I put that in there because I've actually, like I said once, somebody said, what's a girl? Well, girls have that too. Usually it's 1 to 2 months of age, progressive projectile non-bilious emesis. What's interesting is it's pretty clear, kids who had surgery for other things and that kind of thing, you're not born with pyloric stenosis. The pylorus thickens with time. All right? So you're not born with it. So they have a progressive spitting up. All right? The kids who spit up from the time of birth, you've got to think about something else. You can think angular pancreas. You can think, malrotation, all sorts of other things. But this is something that develops with time. Again, the electrolyte changes, and this is a key one. They love this for the board exams. I like to use this as a question on board exams, is hypochloremic alkalosis. You're losing stomach acid. You lose the hydrochloric acid in your stomach. Hydrochloric acid, so you're alkalotic, and chloride, because you're losing chloride. The diagnosis of pyloric stenosis, you palpate the olive. How many of you have ever felt an olive? All right? And I'm not talking about a salad bar. Okay? It's tough. It's tough. I've been doing PGI a long time. You have to have them relaxed. It's helpful if you're trying to feed them. Of course, they're probably NPO because they're spitting so much, and you're hopefully going to get their electrolytes corrected and send them to the OR. But in theory, the best way to feel is kind of slightly recline, feeding them so they're relaxed, and then rolling your finger over the olive. That doesn't happen very often. Ultrasound is the way most people make the diagnosis. And an upper GI, if you have a kid and, sometimes it is a little fuzzy, that also helps. First, rehydrate them. Get them hydrated. Get them hydrated. Correct their electrolytes. And then you do the surgical pyloromyotomy. Fix the fluids. This is not a surgical emergency. This is not like a appendicitis where it's going to rupture and that kind of thing. Pyloric stenosis is something that needs to be surgically fixed, but it's not something that they don't rupture. They're like get them tuned up. Get them tuned up before they go to the OR. And this is a pyloric stenosis. All right. This is the string sign. All right. You see the string of barium going through that thickened pylorus and along the bulb. And this is also actually the railroad track sign because you can actually see. What happens is the channel here is very thickened. It's actually almost lumpy bumpy, and you can actually get secondary channels, and it's thickened, and you can see these crossed lines. If you look at this real careful, you can also see the railroad track sign. It kind of gives you both of those radiologic signs seen on upper GI for pyloric stenosis. Gastric problems, outlet obstruction out of the stomach is very rare. You can see a pyloric web or atresia. Again, the treatment for these is surgical. Microgastria is a small tubular stomach. It's usually associated with other anomalies. As the kids grow, it gets better with time. Some surgeons in the past have tried to do surgical kind of approaches to this and construct the stomach, and it's just abysmal. Best thing to do is get them to grow, do continuous drip feeds to get past that tubular stomach, and eventually it'll get bigger, and you can gradually stretch it with feedings. Time is on your side. Erosive gastropathy, obviously stress will do it. Now, I'm not talking about stress like finals week or taking the board exam. I'm talking about stress like shock, sepsis, burns, or a head injury. All right. Prolapse, you see a lot of tears. We see this very commonly. Kids who have very severe vomiting, forceful vomiting, they'll retch. You'll see the Mallory-Weiss tears where the stomach is kind of retroflexed through the esophagus. Some drugs will do it. Obviously, your nonsteroidals and aspirin. Again, nonsteroidals are in big use right now. It's the season where everybody's coming back to school and they, quote unquote, were going to stay in shape all summer and they never did. And you can also see it with distance runners. The folks who run miles and miles and miles will get an erosive gastropathy from that. Non-erosive gastropathy. Number 1, H. pylori. Most common cause in kids. You can also see the Crohn's disease. There is allergic gastritis as well. You'll see eosinophils in the lining as well. Eosinophilic gastritis, which involves the entire thickness. Meniere's disease, which is the CMV infection of the stomach lining. That's the primary CMV. Lining is swollen. It has this very characteristic hypertrophic look. They actually have the protein losing fluid come out of that, and they actually have protein difficulties. CMV infection, and it usually resolves over several months, and you just kind of support them until their body figures out how to get rid of the virus. Ulcer disease, again, another pet peeve of mine is cannot diagnose on an upper GI in children. All right, children, the GI tract is a little smaller lumen. Things are folded a little more. The angles are a little more acute. You'll see all these little pockets that develop. And so your upper GIs will show all these little pockets, and the barium will collect in a little pool, in a little spot, and they'll say, ulcer. They'll tell you, this kid has an ulcer. And then they'll send them to me, and I'll scope them, and to be honest with you, there's no ulcer almost always. Almost always. So you have to be aware of that. If your radiologists primarily do adults, they will often overcall these things on children. Okay? And you understand a little bit that they don't want to miss something, but upper GI is not the way to make it. Endoscopy and biopsy is a definitive test. And the other thing about an endoscopy and biopsy is if you did the upper GI for belly pain, you rely